Sir, we'll start, sir.
Okay, we'll start. Today we'll be discussing about management of hemorrhagic stroke. Next slide. As all of you know, am I audible?
Yes.
Okay. As all of you know, intracerebral hemorrhage is a medical emergency. Most of the patients will have low GCS. At around 20% of patients will have low GCS, and around 50 to 20% will have poor deterioration after the hospitalization. So you need to monitor aggressively by seeing blood pressure or GCS coma scale. Next slide. Okay. Intracerebral hemorrhage classified as spontaneous hemorrhages and secondary intracranial hemorrhages. In spontaneous intracranial hemorrhage, intraparenchymal bleeding in the absence of any surgery or any trauma. All these come under spontaneous hemorrhages. Again, spontaneous hemorrhages are classified as primary and secondary. In a primary intracerebral hemorrhage, it constitutes maximum number of cases, around 70 to 80% of the cases. Causes would be hypertension or amyloid angiopathy. Secondary, all of you know, any infection, vascular malformations, vasculitis, tumors, or any drug abuse or cortical vein thrombosis, these will cause secondary intracerebral hemorrhages. Okay, next slide. You can classify stroke as ischemic and hemorrhagic. Hemorrhagic mainly extraaxial and intraaxial. In extraaxial, EDH, SDH, and SAH will come. These purely will be managed by neurosurgery. So whenever you receive the patient, you diagnose the case. It is extraaxial. You take a referral, or you can refer the patient to neurosurgery. If it is intraparenchymal, we can manage the cases. In intraaxial, again classified as intraparenchymal, that is gangliocapsular or lobar bleed, or intraventricular hemorrhages. Again, intraventricular hemorrhage may be primary or secondary. Primary intraventricular hemorrhages most of the time will be secondary to aneurysm causes, and secondary intraventricular hemorrhages may be due to the rupture of medial thalamic blood into the ventricular canal, that will causes the secondary intraventricular hemorrhages. Okay, next slide. We'll see some few of the important causes. You classify the bleed as deep or posterior fossa bleed, or lobar bleed, or subcortical or gangliocapsular bleed. Deep or posterior fossa intracerebral hemorrhages most oftenly seen secondary to hypertension, diabetes, or any lacune, chronic lacune. Or secondary causes in macrovascular causes include arteriovenous malformations, aneurysms, AV fistulas, cavernous malformation, cavernomas, and cortical venous thrombosis. In lobar ICH etiologies, most oftenly we see cerebral amyloid angiopathy, arteriosclerosis, and macrovascular causes. And subcortical, like gangliocapsular bleed, most oftenly secondary to the hypertension. Next slide. Secondary causes you should be aware of, because most oftenly we label bleed would be secondary to hypertension. So some of the causes to be ruled out in a particular clinical setting. If a young patient comes, you need to look for the vascular malformation. If an elderly or in a young patient with preceding history of headache, nausea, vomiting, hemiparesis, frequent seizure episodes, in that scenario, you need to rule out the tumors. And if a patient is now in case of bleeding diathesis, like hemophilia, or if patient is on any oral anticoagulant or any fibrinolytic treatment, in that setting also, your ICH would be the possible. And another cause would be amyloid angiopathies or CNS vasculitis. If a patient is a chronic drug addict like amphetamine or chronic cocaine, that will also cause intracerebral hemorrhages. Sometimes after infarction, hemorrhagic conversions will be there. That will also cause intraparenchymal hemorrhages. Head trauma and other miscellaneous causes like vascular abnormalities, most oftenly moyamoya disease, RCVS, CADASIL, or arteritis or infective endocarditis do also causes non-hypertensive causes of the intracerebral hemorrhages. So don't label all the causes would be attributed to the hypertension. So you need to rule out all these causes, even though clinical setting not favoring hypertension only. Next slide. Mechanism of the brain injury, it may be secondary to primary or secondary. Primary brain injury may be secondary to direct effect of hemorrhages on the intracerebral neuron, that will damages the that will damage the neuron, that will causes the death of the neuron, that will leads to the primary injury. Secondary may be secondary to your mass effect or raised ICP, that will causes the secondary brain injury, or sometimes secondary to hypoxia or mass effect, that will also leads to the neuronal damage, that will cause secondary brain injuries. Sometimes after degradation, the hemoglobin and iron products of the RBCs, that will also leads to the toxicity due to the pre-radical injuries. Okay, next slide. Same slide. First, within 6 hours, there will be chances of primary injury secondary to the hematoma expansion. It may be secondary to raised ICP, hydrocephalus, or herniation. Secondary injuries predominantly will occur after 6 hours of the stroke. It may be secondary to cerebral edema, inflammation, or toxicity from the blood products due to the antioxidant failure of the antioxidant mechanism. Next slide. So when you receive the patient, you should note down the time. Not only window period is not only for your ischemic stroke. You should always treat hemorrhagic stroke also equally as your ischemic stroke, because raised hypertension, end organ failure, or increase in the hematoma, that will also leads to the damage of the neurons aggressively. So you need to treat hypertensive stroke or intracerebral hemorrhages as equally as your ischemic stroke. Symptoms, as all of you know, patient will have features of raised ICC like headache, focal deficit, seizures, altered sensorium, poor GCS. Okay, and other vascular risk factors should also be addressed. Hyperlipidemia, hypertension, diabetes, metabolic syndromes do also causes intracerebral hemorrhages. You should always checklist the drugs patient taking priorly. Dual antiplatelet with anticoagulant combination, or if a patient taking vasoconstrictive agent, especially in a patient of migraine, they receives the vasogrin or triptan derivatives. If a patient is chronic drug addict, sometimes he may receive the cocaine or marijuana, that will also causes severe cerebral vasoconstriction, that will lead to the intracerebral hemorrhages. Okay, again, systemic conditions like chronic kidney disease or chronic liver disease, malignancy, hematological disorders, that will also leads to the coagulopathy, finally ultimately leads to the intracerebral hemorrhages. This is the flow chart you should be aware of whenever you receive the patient of intracerebral hemorrhage. You checklist the other causes also, not only attribute to hypertension. Okay, hypertension, it may be sometimes reactive hypertension, so you should not attribute only hypertension as a cause of intracerebral hemorrhage. So always look for these mentioned causes also. Okay, next slide. As I told earlier, same, when you receive the patient, you check for ABC, vital signs, and you need to see for the other organ, because hypertensive hemorrhages, there will be chances of end organ damage like acute LV dysfunctions, myocardial infarction, or any vasoconstrictive events, or pulmonary edema, or acute kidney injury may also occur due to the raised blood pressure. So you need to address those also, and you need to manage the hypertensive emergencies also, and send the routine blood investigation, especially platelets, INR. If in case you are suspecting any inflammatory conditions like vasculitis, you need to send for ESR and CRP. If patient receiving any anticoagulant, that time you can send the detailed coagulation parameters, and data sometimes specific tests for newer oral anticoagulants, you can send per factor 10A assess. And if patient taking any chronic drug addicts, or any he's taking any neurostimulants, you need to send for urine toxicology screening before within 24 hours of the stroke. And if you are suspecting any press or any pregnancy related events, you need to get the UPT done, or urine albumin done also. Cardiac specific, if you're suspecting any acute MI or LV dysfunction, you can send for troponin or BNP proteins, and routine ECG screening should be done. Okay, next slide. Okay, these are the few factors which are very important. Some of the factors that associated with the increased morbidity and mortality. So say for an example, if a patient is having thrombocytopenia, there will be risk of increase in the hematoma expansion. If a patient is having acute kidney injury, that will again aggravate the blood pressure, that will also leads to the increased size of the hemorrhage. Hyperglycemia also carries the worst prognosis, so you need to maintain the blood sugars level at around 150 to 180 range. And elevated troponin, that again indirectly indicates the cardiac involvement in the hypertensive emergencies. If a patient is having anemia, again it will also increase the hematoma. If a patient having anticoagulant related hemorrhage, that will also progress over a time, and patient may deteriorate in the further hospital stay. Okay, by identifying the CT angiography sign, that is spot sign, I will tell you in the next slide. That would be better. Next slide. So emergency. So whenever you receive the patient, do ABC. If GCS is 4, 8 or less than 8, better you intubate in and put on mechanical ventilator with the setting of hyperventilation, proper position, and CO2 washout ideally would be the better choice. And baseline severity scores you should assess. So NIHS can also be used in hemorrhagic stroke also. And one more score is there, ICH score, the intracerebral hemorrhage score is also there. That would also be helpful for the prognostication and the worsening. So we can assess the patient. If patient deteriorate also, we can take care of him. Next slide. Okay, this severity score include NIHS and ICS score. I will tell you in the next slide. Okay, so ICS score and NIHS score baseline should be always done whenever you receive the patient in the emergency, so that if any deterioration from the baseline severity score, we can opt the patient for the any surgical interventions. So this is very important. If you receive any patient of intracerebral hemorrhage, kindly calculate this score. This is very easy score. It contains 5 points. Total scores, maximum score would be 6. It contains parameters. Glasgow Coma Scale, that is 3 to 4 will carry points 2. If Jesus is more than 13 to 15, it carries 0 points. If the ICH volume, I will tell you how to calculate the intracerebral hemorrhage volume on the normal CT. If it is more than 30 centimeter, it will carry 1 point. If it is intraventricular extension is there, again 1 point. If it is infratentorial, that is cerebellum, any brainstem bleed is there, again 1 point. If age is more than 80, carries 1 point. So total maximum points would be 6. 5 and 6 would carries 100% mortality within 30 days of hospitalization or within 30 days of admission. So 5 and 6 will carry grave prognosis. Next slide. As I told earlier, if ICS score is 0, so 30-day mortality will be 0. If ICS score is 1, 13% of the mortality will be there within 30 days of stroke. If 2, 26%, as on like 5 and 6 is there is 100% of mortality. So you can explain the patient attenders regarding the mortality. If a patient is having this kind of score, this will be mortality rate. So condition can be explained to the patient depending on this data. Okay, you should be knowing how to calculate the ICS score. Okay, you can keep this copy in emergency also. ICS score and prognosis 30 days mortality rate also, you can take a printout and keep it in the emergency so that you can explain the patient attenders. Okay, next slide. Okay, ideally CT scanning would be the better option because less time and good specificity and sensitivity, because CT scan identify the calcium and the blood very accurately. So better you do CT scan plain brain, so you can identify the bleed. Depending on the type of bleed, again you can plan for angiography. Angiography is not indicated in all the patient. I will tell the indications for CT angiography. Okay, so when you receive the patient, you did the CT scan brain. In CT scan brain, what all the things to be seen? So whether you have to first you have to identify location of the bleed, so supratentorial or infratentorial, because infratentorial bleed will carry poorest prognosis, and you need to calculate the volume of the blood, and you have to see whether the blood is extended into the intraventricle, whether it is extended to ventricles or not, whether obstructive hydrocephalus is there or not. All these things to be seen. Okay, and you need to see for mass effect or herniation signs, and you need to see for spot sign. I will tell the what is the spot sign in the next slide. And etiology also can also be made depending on the site of involvement of the hemorrhage, as I told earlier, like posterior fossa, posterior fossa, brainstem bleed, temporal lobe bleed, basal ganglia bleed will carry different type of etiologies. Okay, so you see the CT, locate the site, calculate the volume, and see for the mass effect or hydrocephalus, identify the red flag for bleeding conversion into bleeding into by identifying the few signs, you can you can see the patient for any further deterioration. Few signs are there, I will tell you in the next slide. Okay, and you can make out the etiology also. Next. Okay, these are the location of the bleed. As all of you know, I think you might have seen all these kind of bleed. Putamen bleed, it is the most common site. Thalamus, subcortical bleeds, pontine, cerebellum, and temporal lobe. So depending on site of involvement, you can write the location of the bleed, and the size and volume I will tell you. Next slide. This is the white, whatever the dot you were seeing, central dot. This is spot sign. This indicates, so you have to do contrast CT, and you need to see for any leakage of the blood from the vessel that will look like a spot, single spot inside the hematoma. So that indicates there is higher chances of expansion of the hematoma and deterioration of the GCS in further time. Like, so if spot sign is there, you should be alert that patient will deteriorate in next few hours. So you will have to identify this spot sign on the CT angiography. Okay. Any doubt in spot sign? This is the prior when they receive the patient, spot sign was there, and after 24 hours of the follow-up, this hematoma expanded. So it indicates if spot sign is there, definitely patient will deteriorate. Okay. So when you receive the patient, you see the CT in the emergency, you make it out this. So you should be you should keep an eye on the patient. So patient might deteriorate in the next 24 hours so that you can plan for further management. Next slide. Okay, these are the few signs. The slide, first one is, that is, this one is, this bleed is, this first image is, bleed is homogeneous and border is regular and entirely well circumscribed. This carries good prognosis. And second one you are seeing, this is irregular and the borders are not well made and heterogeneous bleed is there. Okay, this carries again very poor prognosis. That indicate again the hematoma will expand in the next 24 hours of period. Then third one is, this is called swirl sign. This appears like a swirl. So any any hypodense lesion inside the hyperdense bleed in a swirl pattern, that is called swirl sign. So it again indicates the deterioration of the patient in next 24 hours. And the fourth one is, you are seeing fluid and blood level. Where you will see this one? Anybody can comment? Blood fluid level, where you will see? Anybody? You might have seen in the emergency. Am I audible?
Yes, sir.
Blood fluid level will be seen in the bleeding secondary to anticoagulant overdose. In that, due to the activation of our own body plasminogen system, that will leads to the lysis of the clot, that will leads to the blood fluid level. This is very sure sign of anticoagulant toxicity or anticoagulant overdose that is causing the intracerebral hemorrhage. And next one is the satellite sign. That is like island of blood within the hypodense lesion, that is called satellite sign. And last one is blend sign, that is supportive like blend like structure that is present adjacent to the major bleed set. So these are all signs very important, because in a government setup, most of the time we'll get the city brain plane, we get it done. So if we identify these signs, we can again indirectly we can tell the patient attender, or we can make the ICU availability. So if these kind of heterogeneous pattern, irregular bleed, swirl sign, blood fluid level, and satellite sign or blend sign, if it is there, you should be alert that within 24 hours of this stroke, again patient will deteriorate, may needs surgery or ICU stress. So these are the signs to be identified in the emergency only. Okay. Any doubt in this slide? Kindly ask. This is very important.
No, sir.
No. Okay. Next slide. Okay. This is very important. So you diagnose the condition, patient is having intracerebral hemorrhage. You need to calculate the intracerebral hemorrhage volume, because you can do prognosis depending on the ICS score, and we can again identify severity of the stroke. So depending on the plain CT brain, you can, in the CT console, we can identify by doing just scrolling the length, breadth, and height. But in the plain CT film, how to identify the volume of the intracerebral hemorrhage? Okay. First one that I mentioned, largest cross-sectional diameter. First, you need to take a largest cross-sectional diameter. This is as he marking the red color. This one is the largest cross-sectional diameter. It will come. You should keep it in the centimeter. If it is Like say for example, here they have given 0.5 centimeter. This one is A. Consider this one as a A. Okay, that is B is that is exactly perpendicular to the A. Okay, that also you need to calculate. You need to calculate A, then perpendicular that is B. So you should keep it in centimeter. Say for example, if it is 5 mm is there, you need to mention it as 0.5 centimeter. Okay, and C, in number of slides, the hematoma is present. That is C. Samir, I told you to put one full city's brain plane so that I can explain. Only one image you have put. Okay, go back then. So C is approximate number of 10 mm slice. So whenever you take the CT scan, the around 16 to 20 the CT cuts will come. In that, which all the cuts is having hemorrhages, you need to count it. Okay. Say for an example, if the in a 6 to 7 cuts you get the bleeding, that is a 6 to 7 slice, if you get the hematoma, so you can label it as number of slides in which hematoma is present. That is C. Again, in C, we need to clarify it in the next slide. Okay, the formula is ABC divided by 2. That will your CT hemorrhage volume. Okay, C will be calculated accordingly. Next slide. A and B, you got it, no? Any doubt in A and B?
No, sir.
ICH volume is equal to ABC divided by 2. A and B is no doubt, right? C will C. So whenever you're calculating the bleed, first you have to take the scale and you need to measure in the scale. Again, you need to put in this side row. Okay, it carries around 5 centimeter. Okay, so you need to put on this scale. Then you need to calculate directly. You should not, like, whenever you measure in the scale, don't put as directly. Like say for an example, you take the scale and measure the ICH intracerebral hemorrhage. In the scale it come as 2 centimeter. Don't put directly into 2 centimeter as a value. So again, you need to put the scale on this side one. Okay, you need to see for how much centimeters, how many centimeters of the bleed, how many centimeters of A or how many centimeters of B. Again, you need to put on this scale and you need to calculate. This is your A and B. Okay, any doubt in this?
No, sir.
No. Okay, next slide. So how to calculate C? So C for the number of slides in which the hemorrhage is present. Again, in number of slides, if say for an example, again you need to see the volume of the hemorrhage. Okay, if the volume of the hemorrhage more than 75% of the index slice would be your maximum size of the blade. If say for an example 5 to 6 slices in which the hemorrhage is there, slice number 1 is having more that maximum size, that would be your index slice. Okay. If the other slices are more than 75% of the index slice, you can count it as 1. If it is around 25 to 75% of the hemorrhage, you count it as 0.5. If it is less than 25% of your index slice, you should not count that. Okay, any doubt in this? If any doubt in this, clarify it now only.
Yeah. Sir, can you please repeat it once more?
Suppose you take the CT scan, it will like around 20 slices will be there in CT scan. 4, 4, 4, 4, it will be there, no?
Sir. Yes,
Hello?
sir. Yes, sir.
Okay, you need to select the first index slice, means the maximum bleeding site. Okay, where the A and B centimeter is more, that is the your index slice. Okay, say for an example, A is around 1 centimeter, B is around 0.5 centimeter. That is the maximum size of the bleed. That would be your index slice. Okay.
Yes, sir.
Okay. Other slides you need to see the 7. If it is more than 75% of the index slice, you can give that one as number as 1. If it is 25 to 75% of the index slice, you give the number of 0.5.
Okay, sir.
Okay, if it is less than 25% of the index slice, you should not give any points to that. Okay, say for an example, you took the CT. In the CT, around 7 to 8 slices, you got the bleed. Okay, you can calculate 1, 2, 3, 4, 7, 6, 1, 2, 3, 4, 5, 6, 7. Like in the 7 slides, you got the bleed. Okay, you got that bleeding slides will be around 6 to 7. Again, you need to see whether that is more than 75% or 25 to 75% of the bigger one. That slides only you should consider. The less than 25% hemorrhages you should not consider as a number of slices. Okay, that bigger bleed only you should have to consider. Bigger slice will be considered. Okay.
Yes, sir. Understood.
Understood, no? Any doubt in this?
No, sir.
Ideally, we use the 5 mm thickness slides. Okay, so number of slides in which you got the bleed, the maximum hemorrhage size, though you need to divide it by 2 if the slices are used as 5 mm. If you are using 10 mm slices, there no need of dividing it by 2. Say for an example, your C number is 6. You have taken the 5 mm slices, you need to divide it by 2, so it will come around 3.
Yes, sir.
Is that okay?
Yes, sir.
It would be better. Samir, can you download and put full city like
Yes,
bleed?
yes, sir. Yes.
That would be better. You if you have any images, that only you can. Hello. Samir, other than you can open slide number 19. In that only we can explain. That would be better. Slide number 19. You see, you have taken the city film. You think all this city film belongs to only one patient. Okay, full entire city. You got around six slices. Okay, say for an example, entire 20 slice city will be there. In that only 6 slides you have, in 6 slices only you saw the bleed. So this one, first one is the smallest one. Okay, smallest one is, this is, compare the bigger one where you select the bigger bleed. Bigger one be, I think number 3 would be the bigger bleed. A is vertical, B is horizontal. Okay, you compare this one to first bleed. First one is almost, it is less than 25% of the bigger bleed, so you should ignore this one. Okay, second one is also small, again it is also less than 25% of the bigger bleed. This one also you ignore this. And image 4 and image 5 and image 6, almost it is more than 25% of this bleed, so you can consider these are the slices. Okay, so total slice in this patient would be 1 2 3 4. In 4 slices we got the significant hematoma volume. Okay, say for an example, if it is more than 75% of this picture number 3, you can give slice as a this one. Say what he is marking, it is almost more than 75% of figure number 3, so you can give 1 point to this one. Okay, this figure number 4, it is around 50 to 75%, you can give 0.5 to this slide. And again last picture, it is around so 25 to 75% of the bigger bleed, so you can give 0.5 to this one. So total 0.5 0.5 1 1, so 2 plus around it will come 3 slices. Okay, your C value in this patient would be 3. If the slice thickness in this city is 5 mm, means again you need to divide 3 by 2, so your C value will come around 1.5. Again, I will repeat. You take the bigger bleed would be your picture number 3. So 1 and 2, picture number 1 and 2 are the smaller. So it around less than 25% of this figure number 3. So you should ignore these slices. And figure number 4 and figure number 6 are almost 25 to almost 50 to 75% of this bigger blade. So you can give 0.5, 0.5 to these two. And this one is almost, figure number 5 is almost more than 75% of bigger blade. So you give 1 point. So here you can give the figure number 3 as 1 point, figure number 4 as 0.5, figure number 5 as 1, and figure number 6 as 0.5. So total slice numbers would be around 3. So if you taken 5 mm thickness slides, again you need to divide it by divide this 3 by 2. So it will come around 1.5. Any doubt? Is that okay, or shall I repeat?
No, sir.
If you have
Understood.
any, understood, no?
Yes, sir.
So smaller bit. So 25 and 75%. Again, you have to see the scale. You have to calculate A and B by using the scale. Then you have to, so by seeing grossly, you should not make it. Okay, you take the scale, you measure the length and breadth, and you apply on the city, and you calculate the individual this length and breadth. If it is less than 25%, you ignore that slide. So if it is more than 25% only, you consider those slices for your ICH volume. Okay, is this okay?
Yes, sir.
If you have doubt, clarify it now only. Okay, this is very important because most oftenly we see only city film. We can't go to the console and we don't calculate the volume. So by CT scan film only, we can make it out. Okay, if you have any doubt, kindly ask now only. Consider this whole city as belongs to only single individual. Okay. Okay, next slide. Where we? Okay, next. Okay. This is the spot sign. As I told earlier, by doing the CT angiogram, we can make the hyperdense signal inside the hypodense lesion. This indicates active bleeding inside the hematoma. So again, it carries very poor prognosis because chances of rebleeding and hematoma expansion will be more in this setting. Okay, just you remember the sign: spot sign, satellite sign, blend sign, and irregular non-homogeneous borders. And these are all the red flag for the ICH because these patients will deteriorate soon. Okay, next slide. So when do you want to get CT angiography done? So don't do routinely CT angiogram because again it will add to the cost, and second one's contrast, side effects, all those things to be noticed. So whenever you need, that time only you do the CT angiography. So whenever you suspected subarachnoid hemorrhage, to rule out the heavy aneurysm. If a patient is having any calcification or enlarged vessels, that again indirectly indicates the aneurysm. If a patient is having any dural venous sinus abnormality, suspecting the cortical venous sinus thrombosis, that time also you can do CT angiogram. So doing the face adjustment of the face, you can see venous tree also along with your angiogram. That time also you can do CT angiogram. If the site of the bleed are unusual, if a suspecting that hematoma is very unusual in shape, very unusual in the location, and edema is out of proportion to the presumed time of ICH. If a location of the bleed is like cortical bleed is, they're not following any particular territories. If the abnormal structure like abnormal mass effect is there, necrosis is there, if the bleeding is disproportionate, if the hypertension setting is not there, if the age of the patient is very less, in that setting you need to rule out other vascular abnormality. That time you can order a CT angiogram. Okay, next. So again, I told this is anticoagulant induced bleed. In this, fluid and blood level will be there. Okay, whenever you see this kind of CT, even though a patient not giving proper history, again cross check because management of anticoagulant induced anticoagulant induced bleed would be entirely different from your hypertensive bleed. So whenever you see this sign on the CT, go through the drug list and see for the checklist the drug and see for your coagulation parameters because management is entirely different. Next. So come to the treatment aspect. So triad of management of ICH would be aggressive BP management, if patient is on any anticoagulant, correct the coagulopathy. And third one is management of raised ICP. Okay, we'll come to the BP management. Okay, next slide. There are three trials are there. First initial trial was Interact trial 1, second one is Attach trial, third one is Interact trial 2. The AHA recommendation, recent recommendation, that is 2022 guidelines, it is taken from Interact trial 2. They advise better to maintain blood pressure below 140, not less than 130. So better you maintain the blood pressure between 130 to 150, they say. So ideal blood pressure would be 140 mm of Hg. If a patient, those who presented with a blood pressure of 150 to 220. Okay, so in that you can give bolus and you can manage. If a patient presented to the emergency with a blood pressure of more than 220 mm of Hg, better you start intravenous infusion to reduce the blood pressure to 140 mm of Hg within 1 to 2 hours of hospitalization. Okay, these are the guidelines. Next slide. What all the drugs you are using in emergency? Can anybody tell? What all the drugs commonly used in hypertensive emergencies or urgencies?
Labetalol and nitroprusside are available.
Okay. How will you use labetalol? What are the precautions to be taken when you're using the labetalol or nitroprusside?
We check for the pulse rate, sir. If bradycardia is there, labetalol will not be given. And also, any Krebs or Ronchi is there, then also it's not advised.
Okay, okay, fine. Then other drugs? Esmolol, enalapril, anybody use? Esmolol will come 1.25 mg per ml preparation, injectable preparation will come. Enalapril, I think 10 mg per ml preparation, the total 100 mg vial that will come. You can use those drugs also. Nitroprusside, better you avoid in neurological disorders. Okay, we don't prepare nitroprusside because it will causes increased ICP. Okay, so whenever patient comes to the emergency with a complaint of with a history of raised ICT features or any massive bleed, don't use nitroprusside. Okay, so better you avoid the nitroprusside. This would be better in like acute cardiac condition, not in acute MI. That would be acute heart failure with hypertension, hypertensive heart failure. In that setting, nitroprusside would be the better choice. Don't use in stroke patients. Okay, be careful whenever using in a stroke patient. So labetalol, I think widely it is available. Esmolol and enalapril also good drugs. You can keep it in the emergency whenever labetalol is contraindicated. That time you cannot go and search the drugs. So esmolol and enalapril are widely available. These also can be used. Okay, next slide. Okay, as I told, there are three trials in the ICH management. Just you remember the name. One is Interact trial, second one is Attach trial, third one is Interact 2 trial. So recent guidelines are mainly taken from the Interact 2 trials. Okay, we'll consider the Interact 1 trial, that is they included the patient of around 404 patients. They divided as a two group. One is aggressive management like blood pressure, and the second group would be target of 180 mm of Hg. Okay, in a first group they use the locally available intravenous drug. They lower the blood pressure of 140 mm of Hg within 1 hour, and second group 180 mm of Hg. Okay, finally they concluded that there is no excess of neurological deterioration or other adverse events that are related to the intensive BP lowering. Okay, this was the first trial, that is Interact trial 1. They concluded even aggressive BP lowering will not carry any poor prognosis in the ICH patient. Second slide. This one was the Attach trial, that is antihypertensive treatment in acute cerebral hemorrhage. They included the patient and they used the drug nicardipine. They divided the groups as the systolic blood pressure goal group as 170 to 200, 140 to 170, and 120 to 140. In a 110 to 140 group, there was like some adverse events were noted. They concluded that ideal blood pressure would be around 140 to 170 rather than less than 140 would harm the patient. Okay, this was the second trial, and third one we'll see the Interact 2 trial. Next slide. This was the Interact 2 trial. They included around 3,000 patients. They maintained the blood pressure between 150 to 220 within 6 hours of ICH. So they found that the blood pressure less than 140 mm of Hg, systolic blood pressure, would carry better prognosis and better mortality outcome within 3 months of onset of the stroke. So current guidelines, ASA guidelines says better you maintain blood pressure less than 130, should not go below 130. Okay, less than 140, should not go below 130. So ideal blood pressure would be 130 to 150 mm of Hg within 1 hour of hospitalization. Okay, any doubt in high blood BP management and ICH? You can ask, many doubts will be there. Okay, any doubts? Blood pressure management in acute cerebral intracerebral hemorrhage.
So nitroglycerin can be used, sir?
No, nitroprusside, if patient is having bleed, mass effect or raised ICT features, don't use nitroprusside. Labetalol, esmolol or enalprolate. If available, you can use nicardipine.
Okay.
Okay. Next slide. This is the comparison as I told earlier. Next slide. So one more slide. This is the same as that, like within initiating the treatment within 2 hours of ICH onset, reaching the target within 1 hour can be beneficial to produce the risk of decrease the risk of hematoma expansion. Okay, so better within an hour of hospitalization, you reduce the blood pressure to less than 140, that is 130 to 150, as guidelines says 130 to 150 would be safe and reasonable. Okay, if you reduce the blood pressure less than 130 mm of Hg, it will harm the patient. Okay, so you put on the, you shift the patient to ICU, connect the monitor the blood pressure. If blood pressure is more than 220 mm of Hg, you start the infusion and start maintaining the blood pressure at 130 to 150 within 1 hour of hospitalization. If blood pressure is around 150 to 210 is there, just you give the bolus dose repeatedly. After bolus dose, if the blood pressure is settled, you can shift to oral drugs. Okay, next slide.
Can we reduce suddenly, sir?
Tell me.
Within 1 hour, we can reduce from 220 to 140, sir?
Yes, within 1 hour.
Yes, sir. There is no
within 1 hour.
Yes, sir.
Not in ischemic stroke, hemorrhagic stroke. Okay,
yes, sir.
Hemorrhagic, you should be aggressive. Like if you reduce the blood pressure within 1 hour, it will carry good prognosis. Okay, if you delay the treatment, again hematoma will expand, it will leads to the deficit, and again it will carry poor prognosis for the patient. Okay, so better you reduce the blood pressure less than 1 hour. You can choose either infusion or bolus depending on the presentation blood pressure. Okay, next slide. Okay, second clinical setting would be if a patient taking acetram or warfarin or any rivaroxaban come to the emergency with raised ICT features. You got the CT done, it was showing bleed. Okay, then what to do? Okay, this would be, I think you might assume a number of cases. We'll see the flow chart. Okay, next slide. First, you stop the anticoagulants or antithrombotic agents. Next slide. Okay, so if a patient receiving vitamin K antagonist, give 5 to 10 10 milligram of vitamin K, and if needed, you can repeat it after 6 hours. And one more newer drug, that is 4-factor PCC. Anybody use this prothrombin complex concentrate? Sandeep sir or anyone? This one is a newer drugs. This contains coagulant factors like 7, 8, 9, 10, and prothrombin C and prothrombin S. This is a newer product. I think Intas people, they have introduced. This would be better. Nowadays we are using this. So in government setup, it would be difficult because government this is too costly. So 4-factor prothrombin complex concentrate, PCC, would be administered. You check the INR. If INR is more than 1.4, you can administer prothrombin complex concentrate. Okay, again you can repeat INR after 1 hour. If it is still persistently high INR, you can give further 2 to 4 units of fresh frozen plasma. PCC may have fewer complication and they correct INR more rapidly compared to FAB. If patient is affordable, if PCC is available, that would be better option in a coagulopathy setting. Next slide. Okay, this is the this is a brand name, that is Kcentra. This is also known as Kcentra is the company brand name. Content would be prothrombin complex concentrate. This contains vitamin K dependent coagulation factor, that is 2, 7, 9, and 10, and some antithrombotic proteins like protein C and protein S, which will help to reverse the acquired coagulation factor deficiency that was induced by the vitamin K antagonist. Even you can use in direct thrombin inhibitors or factor 10A inhibitors also. So you receive the patient was taking warfarin or acetram, give the vitamin K 10 mg IV, check the INR. If INR is between 1.5 to 3.9, you can give prothrombin complex of 25 units per kg IV. If INR is 4 to 6, give 35 units per kg. If INR is more than 6, you give the 50 units per kg infusion. And check the INR at 1 hour, 6 hour, and 24 hours after the stroke. Okay, and repeat the INR after giving your PCC. If the persistent, if PCC can be repeated again one more time, but the issue is the cost. So even after giving the PCC, if the INR is more than 1.5, you can give 2 to 4 units of FFP. Okay. And if INR is more than 1.5 at 6 hours, you can repeat the vitamin K 10 mg IV. Okay. If patient taking any thrombin inhibitors like dabigatran, if within 2 hours, if patient, say for example, morning dose patient has taken, he has come within 2 hours of stroke, within 2 hours to the emergency with a complaint of stroke, that time you can give activated charcoal, you can do stomach wash, and the company people will also provide the anticoagulants, that is antidote for dabigatran, that is idarucizumab. I think you might have read. So you need to give 2.5 gram IV over a period of 10 minutes. You can repeat if needed. Okay, it will correct the APTT and thrombin time immediately. If a patient is a known case of CKD, that time you should not wait for all this drug. Better you shift him for dialysis. That will take care of this dabigatran toxicity. Okay. And third one would be if patient taking any rivaroxaban, apixaban, or endoxaban, same. If come within 2 hours, just you give the stomach wash. And if reversal with PCC attempted, then give PCC according to the INR status. And these are not removed by any dialysis. So PCC, if not improved by PCC, you can give FFP. Okay. Any doubt in this slide? Commonly, you might be seeing anticoagulant induced ICH. Okay. Any doubt in this slide? You can ask.
No, sir.
Okay. Next slide. Again, this is the flow chart. You can go through this same as I told earlier. Same slide. Just you see the flow chart whenever you got the free time. And one more setting would be heparin, as we routinely use most of the time outside. They will give heparin after that patient developed the bleeding. If they come to the hospital, protamine would be the choice. It reverses the toxicity of the heparin. Okay, protamine sulfate you can use. Next slide. So next setting would be if a patient received thrombolytic agent like tissue plasminogen activator, altilase, or tenecteplase received. After that, developed the hemorrhagic conversion of the infarct. That setting, your cryoprecipitate would be the better option. You can give 10 units of cryoprecipitate. So you take the baseline fibrinogen level and give the 10 units of cryoprecipitate. Even after giving the cryoprecipitate, if fibrinogen level is still on lower side, if it is less than 150 mg per deciliter, again you need to repeat the dose of cryoprecipitate. So if it is more than 150, you can wait and see. If cryoprecipitate is not available in your setting, you can give tranexamic acid 10 to 15 milligram per kg intravenous dose. You can give infusion for a period of 8 hours. If needed, you can repeat the dose also. Or 3 amino caproic acid 4 to 5 grams intravenous can also be given. So in a case of thrombolytic induced intracerebral hemorrhage, cryoprecipitate would be the better option. According to the fibrinogen level, we can plan for whether to repeat the cryoprecipitate or not. Okay. Next slide. So antiplatelet induced bleed. In this setting, usually we don't use platelet transfusion. Okay, if a patient taking dual antiplatelet or triple antiplatelet for other reasons, if we develop the bleed, that time there is no recommendation to give the platelet transfusion. It can be indicated whenever patient is planned for surgical intervention like hematoma, evacuation, or any microinvasive surgery, in that time platelet transfusion would be benefited. Or else, if not planned surgery, don't give any platelet transfusion. Just wait and watch and monitor the raised ICT features and take proper anti-edema cares. Next slide. This is a slim side. You can see. Okay, next slide. So in our setting, it is very difficult to monitor the ICP because to putting the intraventricular or intraparenchymal ICP monitor, it would be difficult. It will be done in tertiary or higher centers. They will put the monitor inside the ventricle or brain parenchyma and they will measure the intracerebral pressure. Ideal goal would be maintain the intracerebral pressure less than 20 mm of Hg and cerebral perfusion pressure more than 60 mm of Hg. If it is not maintained, that time you need to give anti-edema measures. Ideally, it is very difficult in our setup. Okay, next slide. So, how to like treat the elevated intracerebral pressure? Okay, head end elevation would be the first choice, and ventriculostomy if needed. Like if patient is having any intraventricular hemorrhages, obstructive hydrocephalus, that time CSF drain would be the better option. And third one, as all of you know, most commonly osmotherapy. Mannitol can be used first 3 days. So dose would be around 1 to 1 gram per kg. Stat followed by 0.25 to 1 gram per kg. It can be repeated 4 to 6 hourly. And you need to see for serum osmolarity should be between 300 to 320 and adequate urine output should be there. You need to monitor for urea, creatinine, sodium also. And if patient is having acute failure symptoms like LV failure, acute kidney injury, or hyponatremia, that setting you should not give mannitol. In that setting, hypertonic saline would be the better choice. You can give bolus 30 ml of 23% of NaCl. You can start later, you can start the infusion by using 3% NaCl. Ideally, the sodium should be maintained between 140 to 150 milliequivalent per liter. You can give up to 5 to 7 days. So you should ideal sodium level to be maintained between 140 to 150 milliequivalent. Any doubt in this slide? And don't give empirical mannitol to all the patients. You see, if a patient is having features of raised ICP, say for an example, patient is having papilledema, LR palsy, severe headache, vomiting, massive bleed, midline shift, signs of herniations are there. In that setting, only you give the mannitol. So don't give mannitol to all the ICH patients because it has its own like mannitol also have so many side effects like kidney injury, hyponatremia, alter the serum osmolarity. Okay, that will also carries the bad prognosis. So whenever indicated, that time only you give the mannitol. Any doubts in this slide?
No.
Okay, next slide. So should not give steroids should not be given. Okay, and hyperventilation technique should be used in the ventilator setting. Better maintain PCO2 at 30 to 35 mm Hg. Okay, other like if needed surgical indications, I will tell you in the next slides. Next slide. Okay, management of hematoma and edema. Patient with asymptomatic. Okay, mannitol and hypertonic solutions are the first line medical therapies to decrease the ICP. Patient with large ICH more than 30 ml or symptomatic perihematoma edema will be benefited by giving the hypertonic saline by maintaining the sodium at around 140 to 150. You can give it up to 7 to 10 days to minimize the edema. Okay. Mannitol and HTS can be used emergently for only worsening cerebral edema, elevated ICP, or impending herniation. In other condition, don't give these anti-edema measures. Okay. Next slide. Okay, we'll see for the surgical intervention. Next slide. In a intracerebral hemorrhages, the intervention are not very clearly defined. As first trial was Stitch trial, they concluded that the hematoma evacuation would be benefited if a patient is having bleed that is within 1 centimeter of cortical surface. That those kind of patients will get the benefit. If the deep bleed is there, if the GCS is very poor, less than 5 GCS, in that setting, the surgical management will not benefit. It has equal benefit as your medical line of management. Okay, next slide. And stage 2 trial, they consider the patient of GCS coma more than 8 and hemorrhages of size to 10 to 100 mm 300 millimeter of mercury, and without any intraventricular hemorrhages, admitted within 48 hours of the intracerebral hemorrhages. Here also they concluded there is no much benefit from the surgical intervention. Most of these trials, they concluded only for mortality benefit rather than morbidity benefit. Supratentorial hematoma evacuation in a deteriorating patient would be consider the life-saving measures. Only mortality benefit would be there if the supratentorial hematoma evacuation is done. There is no mortality benefit as of. Next slide. So again, same. Newer technologies have also come. Minimal invasive surgical evacuation. This is the one. Second one is your decompressive craniotomy. Third one is if patient is having any hydrocephalus, that time they will do extraventricular drainage. There are the 3 surgeries which are commonly they are doing. Minimal invasive surgeries are ideally recommended in a patient of Glasgow coma scale of 5 to 12 and the CT ICH volume of more than 20 ml. Again, most of the studies concluded that only mortality benefit without any morbidity benefit. Okay, if a patient having impending raised ICT features and started having herniation sign, that time if you do the surgery, that will carries only mortality benefit rather than morbidity benefit. Okay, next slide. Again, one more slide. This is craniotomy for supratental hemorrhage. If a ICS score of more than 10 cc with significant neurological deficit, that time craniotomy would be helpful. But functional benefit is again uncertain usefulness. Most of the time in intracerebral hemorrhages, surgical intervention will not carry any good prognosis unless having severe signs and symptoms. Only mortality benefit is advised. Next slide. Yes, definitely. In case of cerebellar hemorrhages or posterior fossa hemorrhage, particularly in cerebellar hemorrhage, it carries very good prognosis. If patient is having cerebellar hemorrhages, even more than initially they used to tell more than 30 cc of bleed in a cerebellum to be drained, but newer guidelines says even less than 30 ml, patient is deteriorating neurologically, or patient is having any brainstem compression, or a patient having any hydrocephalus or ventricular obstruction, even small amount of bleed should also be evacuated. It is indicated, craniotomy indicated for posterior fossa hemorrhage. The following conditions would be, as I told, deteriorating GCS, brainstem compression signs, or hydrocephalus. So cerebellar, whenever you receive the patient in the emergency, patient is having cerebellar bleed, you should be very alert, because cerebellar bleed may worsen at any time, because most of the vital structure will be compressed by cerebellum, hydrocephalus will occur, and small area of posterior fossa, so herniation chances will also be more. You should be very alert whenever you receive the cerebellar bleed patient. Okay, next slide. Okay, as I told earlier, whenever patient is having poor GCS of less than 8, large hematomas, and with maximum midline shape and elevated intracerebral pressure, even after proper medical line of management, you need to refer the patient for neurosurgical intervention, for especially decompressive craniotomy. Okay, this is level 2B. Level of evidence is C and class of evidence is 2B. Any doubt in surgical intervention in ICS? When to refer? If no doubts, just
No, sir.
change.
Yes.
Okay. So, okay. Medical and versus surgical, as I told earlier. Medical line of management, like minimal symptomatic, brainstem hemorrhages, poor outcome, high ICS score. Like if patient is having ICS score of 5 and 6, will not survive. In that patient, if you do also, it will not be helpful. If affecting lobe is dominant hemisphere, because hematoma evacuation, during the hematoma evacuation, we may damage the cortex. It will lead to the language disturbances, seizures. So in that setting also, we can be avoided. If poor GCS is like less than 5, if the age of the patient is more than 75, if deep bleeds like basal bleeds are there, in that setting, medical line of management would be better. If a patient is having midline shift, herniation, brainstem compression, volume of 10 to 30 cc, favorable location, lobar or cerebellar bleed, young patients are there, in that setting, surgical options would be better compared to the medical option, medical line of management. Okay, next slide. Better you shift to next slide. Intraventricular hemorrhage management. So you receive the patient of intraventricular hemorrhage. You need to see whether patient is having, whether the CT scan showing any hydrocephalus or not. If hydrocephalus is there, definitely you need to, next slide, definitely you need to take the neurosurgery reference for extraventricular drainage or any shunting. Okay. So whenever you receive the patient, you saw intraventricular hemorrhage is there and patient is having hydrocephalus also and deteriorating sensorium is there, refer the patient to neurosurgery for further management. Okay, just you remember hydrocephalus and intraventricular hemorrhage, that is your surgical cases. That time you refer the patient. Again, it carries only mortality benefit without any functional benefit, functional outcome benefit. Next slide. These details, like it would be too much for you people. Better you remember intraventricular hemorrhage is there or not, whether patient is having hydrocephalus or not. If it is there, you refer the patient for extraventricular drainage or neuroendoscopic guided treatments. Okay, next slide. Again, I told it is better to maintain the sugars between 100 to 150, not more than 180 or not less than 110 mmHg. Both hyperglycemia and hypoglycemia carries poor prognosis. Temperature normothermia should be maintained. There is no guidelines regarding the therapeutic hypothermia as of now. Okay. Treatment of fever should be aggressive. Okay. Next slide. Again, in seizures, prophylactic anti-seizure medication should not be given. Can anybody tell where you can give prophylactic anti-epileptic drug in neurology? I think earlier I told. Can anybody tell? Prophylactic anti-epileptic drugs.
Sir, if there is gliosis and seizure episodes happen.
No, prophylactic without seizure. If you want to give anti-epileptic drugs, which all condition you want to give, which all the condition should be given. Patient is not having any acute seizures or any seizure history. Few of the conditions we should give. Any conditions you are aware of? Okay, there are few indications. One is subarachnoid hemorrhage. Even though without seizures also you need to give the anti-epileptic. And second one is neurocystic sarcosis in colloidal and vesicular stages. These are all conditions. Definitely patient will have 100% risk of occurrence of seizure. So in these two conditions only, you can give prophylactic anti-epileptic drugs. Okay. Other condition, you don't give any prophylactic anti-epileptic drugs. Okay. Next slide. Again, this is the same slide. Okay. Next slide. Okay. DVT prophylaxis. As all of you know, stroke patient will have hemiplegia or hemiparesis. So hemiplegia, if lower limb completely plasic, that time chances of venous thromboembolism will be more. So in a patient of ICH setting, you cannot give anticoagulants also. So in that time, you can use better intermittent pneumatic compression packs will be there. That would be better options. Okay. And up cessation of bleeding, you can give heparin after 2 days. This is, you should wait for 2 days or 48 hours. If patient GCS is not deteriorated, you can give prophylactic dose of low molecular heparin. Okay. Next slide. As I told, so intermittent pneumatic compression can be given. Again, you can use heparin in a prophylactic dose after 24 to 48 hours of the ICH. If patient is having proximal DVT, he presented to the emergency with the ICH, that setting you cannot give anticoagulant. Rather than giving the anticoagulant, you can refer the patient, you can take an opinion from CT-based surgeon to put a IV filter, inferior vena cava filter, so that we can prevent the dislodgement of this clot to the lungs or any other systemic other system. So in the setting of proximal DVT, DVT that is present in the thighs or the proximal veins, That time, to prevent the pulmonary embolism, you need to take a vascular surgeon reference to put a IV filter. In that setting, you cannot give heparin because acute bleed within 48 hours. You should not give any anticoagulant. If you give, again, hematoma will expand. It will deteriorate the patient GCS. Any doubt in thromboprophylaxis?
No, sir.
Okay, next slide. Next slide. Okay. Risk factor to be considered for the recurrent ICH. If a patient having lobar location in the initial ICH will have higher chances of getting the recurrent ICH. Older age, any microbleeds on the MRI, ongoing anticoagulation, and genetic mutation of apolipoprotein E2 and E4 allele mutation that will carry high risk of recurrent intracerebral hemorrhage. In that setting, you need to explain the patient and attendants regarding the future reoccurrence of these kind of strokes. Okay, next slide. Okay, as I told, like blood pressure should be 130 to 180, not less than 130. Okay, next slide. Say for example, if a patient is having mechanical heart valve and on anticoagulant, he developed the intracerebral hemorrhage. In that setting, again, you need to give the anticoagulation. If you stop the anticoagulation, again, stuck valve will develop, patient will develop with acute LV failure. Again, if you give the anticoagulation, it will lead to the hematoma expansion. So in high risk of thrombotic events like mechanical valve or left ventricular assisted devices patient, early resumption of the anticoagulation is reasonable. Early means there's a guidelines is 1 to 2 weeks at least we need to wait. Again, you need to see for benefit versus risk. If benefit is more than risk, you need to start as early as possible. If risk is more, that time you can consider for LA occlusion device, or also left atrial occlusion device, left atrial appendial occlusion devices are also there to prevent the embolic stroke. And statins, there is no benefit. Don't give any statins prophylactically in a patient of intracerebral hemorrhages. Most commonly, most of the people, they give statins. Okay, don't give statins in an intracerebral hemorrhage patient. Avoid unnecessary NSAIDs because that will again carries the poor prognosis due to increase in the intracerebral hemorrhages. Okay, next slide. Again, physiotherapy, don't take a physiotherapy reference within 48 hours because in acute stroke there will be hypersympathetic surge will be there. Again, if you mobilize the patient, again if you do physical exertion, that will carry poor prognosis, that will lead to the reoccurrence of bleed or hematoma expansion. Better you avoid first 48 hours of the stroke, better you avoid rehabilitation therapy. So after 48 hours you can take physiotherapist reference for the physiotherapy. Okay, next slide. This is reasonable after stroke. Once patient discharge, better to maintain blood pressure 130/80 to prevent the further hemorrhagic events. Okay, after discharge 130 to 80, and acute setting first 24 to 48 hours 130 to 150. Okay, any doubts? Common causes of spontaneous non-traumatic ICH include hypertension, amyloid, and coagulopathy. Goal would be control the ICP, reduce the mass effect, prevent the secondary brain injury. The role of surgery in supratentorial spontaneous ICH is not clearly beneficial, but may be useful in a patient with superficial lobar bleeds with higher GCS on the admission. Okay. Any doubts in this session regarding ICH?
No, sir.
No, clear. Next class, what do you want to? Which all the topics you want, or you are going to present case, or what do you want actually? Next class. First, you clarify your doubts in.
Approach to seizures.
Hmm?
Approach to seizures.
Seizures. Okay. Any doubts in this session?
Sir, any role of glucocorticoids, sir?
Glucocorticoids in stroke?
No, sir. In intracranial hemorrhage. Routinely,
You are asking like steroid absolutely contraindicated.
yes,
If ICP bleed in a malignancy setup, like say for an example, patient have like malignancy and superadded infections that are causing, in a case of vasculitis that is causing the stroke, or a malignancy that is malignancy with secondary infection, or any infective etiologies that are causing the intracerebral hemorrhage, that time you can give. Your routine ICH should not be given. That will be harmful. Okay, don't give in routine or ICH cases.
So if the patient throws seizures, then anti-epileptics are indicated, sir.
Yes, a patient throws a seizure, give. If you are suspecting non-convulsive status epilepsy, say for example, if a patient not throwing any seizures, still having some signs and symptoms of non-convulsive status, say for example, flickering up the eyeball, flickering up the movements, poor GCS, even after treatment, you put him on EEG and see for any epileptiform discharges. If epileptiform discharges are there, even though convulsions, if you are not seeing on naked eyes, so that time by seeing the easy evidence, you can give anti-epileptics. Don't give empirically.
Sir, if there is a brainstem hemorrhage, sir, mannitol is indicated, sir, because of this.
Brainstem only cerebellar hemorrhage you should give. Like other pons and midbrain medulla, in that setting it would not be helpful.
That's all, sir.
Okay. Okay.
Thank you, sir.
Okay.
Next
Okay.
class I will contact you, sir.
Okay. Okay.
Thank you so much.
Okay. Okay. Bye.
Bye.